Month. Really appreciate each of you for being here today. We have a lot of amazing stuff planned for the day, so we're super excited to show you all that we have going on and just have an opportunity to open up the conversation. So first, I am Patrice McGee. I am the Outreach Coordinator Chair for the Atlanta Auburn chapter of the NAMI, which is the National Alliance on Mental Illness. And then we have a couple other folks in the audience that are also a part of the Atlanta Auburn affiliate. We have Ms. Jade, we have Howard, we have Blanche over at the registration table, and then we have Ms. Darlene, who will, and a lot of these people you'll see on stage today as well. And then last but not least, and most important for this affiliate is Ms. Joanne. She is the president of our affiliate, and she put this entire event together. So yes, thank you. I'm super excited to see this event come to fruition. So we're excited to do all the things that she thought of and put together. So the first thing that we are going to do today is we are going to hear a presentation from Dr. Jade. She's going to talk to you about some different things about mental illness. And so I'm going to hand it over to her, and if you'll give her your undivided attention, we will get this started. And thank you, everyone. If you will give her a round of applause as she comes to the microphone.
I hope you guys don't mind me sitting down while I'm talking. Okay. So I'm Dr. Tayyeb. I'm a forensic psychiatrist. I recently took up a job with McIntosh Trail Community Service Board in McDonough. I will continue to live in the Midtown area and be involved with the Fulton County Mental Health Court. For those of you who don't know what the Fulton County Mental Health Court is, it is a diversion program for folks that are incarcerated and have mental illness, and we're trying to move them away from the criminal justice system into treatment and kind of restoring other areas of their lives. For example, help them with housing, employment, staying away from drugs, and basically being contributing members of society. I appreciate that. Thank you. Yeah. Do you need help? What was that? Presentation. No. Okay, so I'll begin by talking about an overview of behavioral health conditions. And then I will open the conversation so that if you guys have any questions about family members that are patients, any questions about medications, or what next steps to do if you have a family member that is involved with the criminal justice system, I'm happy to answer those questions to the best of my ability. So I'll first talk about mental illness in general. The folks that I deal with mostly in the community are those with chronic persistent mental illness. And when we say chronic persistent mental illness, we're usually referring to either schizophrenia or bipolar disorder. Depression can count as a chronic severe mental illness, persistent mental illness, if it is severe enough to affect an individual's social and occupational functioning. But as far as schizophrenia and bipolar disorder go, those are conditions for which folks need to be on medication for a lifetime. And sometimes there are questions about, oh, I have depression, will I be on medications for the rest of my life? Or, I was recently diagnosed with anxiety, will I have to be on medications for the rest of my life? And the way we make that distinction is if your depression caused you to become suicidal, for example, you will need to be on medications. We recommend that you be on medications for the rest of your life. If you had a major depressive episode and we started you on medications, your psychiatrist is supposed to, ideally, reevaluate whether or not you need to be on medication 6 to 12 months after the episode. And if your symptoms resolved, then it is not unreasonable to ask your psychiatrist to try to take you off of your medications. But if you've had 2 or more episodes that were affecting your social occupational functioning to the point where you became withdrawn and were not able to interact with family members as you usually do, or skipped a lot of days of work because of your depression, then we do recommend that you continue to take medications for the rest of your life and adjust them as necessary. Now, the next thing I want to talk about is that each illness has specific signs and symptoms. So signs are basically what we as observers might notice is going on with an individual. So for example, a person might say, I see things that other people can't see, or I hear voices that other people can't hear. Those are symptoms that the patient or individual is reporting. But the signs that I would look for, so for example, if I am asked to evaluate somebody that is incarcerated and they are smearing feces all over their wall, I will go and look for signs. For example, that is a sign because that is disorganized behavior. I'm observing that. If I observe the person talking to themselves, I can document that, saying that, he or she was responding to internal stimuli. I could tell that that person was hearing voices or seeing things. So sometimes when the mental illness is so severe and untreated, they might not even be able to report symptoms. I mean, you can ask them, are you hearing voices? And they'll be doing their own thing, talking to their wall. So it's important to understand that distinction because, for example, even with something as depression, if you have a family member that you might be concerned is depressed, there are certain signs that you can observe. So for example, they might have slowed movement, or they might be very indecisive, or they might have excessive crying spells. And when you ask them, are you depressed, they'll say no. And so they might not always be reporting the symptoms of depression. So the symptoms of depression, you ask patients, are you having any difficulty sleeping? Are you having any feelings of guilt or hopelessness? Have you had thoughts of suicide? And they might answer no to everything. But me as the clinician or you as a family member might see that individual and be like, no, but he or she's not been eating, has lost so much weight, he's up at night. Like those are all signs that that person is going through some mood changes that need to be addressed. So those are as significant as just asking somebody, hey, are you suicidal? Because they might say no, but their actions are different. So actions always speak louder than words is my point. So levels of severity differs from person to person. So we have very, very functioning patients with schizophrenia that are out there in the community that hold jobs, that are on their medications, and those are our success stories. NAMI has a program, peer-to-peer, where individuals who have made it in the community or are contributing members of society with a mental illness and still doing pretty well, where the mental illness is a part of their life but is not their life. It is a diagnosis and it is something that is treated and they're still able to function in all other areas of their lives, and they are able to talk to folks that have recently been diagnosed with a mental illness to help them learn coping skills, to kind of set an example for them. And Ms. Joanne can talk to you more about the peer-to-peer program, but I'm a huge advocate of that program because when I started out as a clinician, I always struggled with the fact that my area of expertise was limited to adjusting medications, where I could clearly see that the person I was treating needed a lot more than that. They needed help with housing, they needed help with employment, and I did not know who to turn to. And I started attending NAMI meetings at the University of Alabama. That's where I trained, and I learned more about NAMI, and I've just become a huge advocate since then. So now, among the top 10 most disabling illnesses for men, it is depression, schizophrenia, and bipolar disorder, as well as alcohol use disorder. And for women, it is depression, bipolar disorder, and schizophrenia. Now, mental illnesses, as a lot of us know, disrupt a person's thinking, mood, and behavior, and most importantly, daily functioning. And that's how we assess severity in the clinical setting, based on how disrupted their daily functioning is. And they can cause disability and distress, but people can and do recover and lead productive, meaningful lives, even if it means that they need to be under the care of a psychiatrist, they need to keep taking medications, they need to keep seeing a therapist. Just as if you were diagnosed with congestive heart failure, you're not going to make it if you don't keep in constant touch with your cardiologist and keep taking your medications. Just like that, for mental illness, these folks need to be under the care of a psychiatrist for the rest of their lives, pretty much. We already talked about signs and symptoms, so I'm going to go through that one. Now, hallucinations are something that are generally talked about pretty much when we think about schizophrenia. And psychosis itself is a break from reality, and hallucinations are just one manifestation of this break from reality. Is, for example, if you're experiencing auditory hallucinations, you're hearing voices that other people cannot hear. And then the other kind of hallucinations that we most commonly encounter are visual hallucinations, where you're seeing things that other people can't see. Now, with schizophrenia, you're never going to just have visual hallucinations, so that's an important distinction. You're mostly going to have auditory hallucinations in at least 60% of the cases. In other cases, you might have auditory hallucinations in combination with some other kind of hallucination. So the visual hallucinations, usually you see that in folks that are withdrawing from alcohol, or they have some form of organic brain disease. So visual hallucination, or dementia, for example, Lewy body dementia, you see a lot of visual hallucinations in the patient. So it's important to kind of make that distinction so folks are not misdiagnosed. But then you can also have hallucinations like tactile hallucinations, where folks might say, oh, I feel that I have bugs crawling on my skin. And that is usually seen with amphetamine use disorder, or if the individual is abusing any kind of stimulants like cocaine, they might experience that, or if they're withdrawing from alcohol. And the less common types are the gustatory ones, where you can have alterations in your taste or alterations in your smell as well, but those are usually associated with seizures. So I just wanted to tell you guys about it. You probably won't remember most of this, but just remember, if it's schizophrenia, auditory hallucinations are the rule. They will hear voices or report that they're hearing voices that other people can't hear. That's the most common type of hallucination. If you see anything else, think about organic brain disease, think about substances. Now, the other form of break from reality that folks that are experiencing psychosis undergo are delusions. And delusions are fixed, false beliefs, despite evidence to the contrary. For example, a patient might believe that a physician has implanted a microchip in their head, or that the government is sending them messages through the television. And delusions are the hardest to treat, and even with antipsychotic medications, but we do the best we can. And the way to do that is not to give in to the delusion, but to do a lot of reality testing with the patient, where, sometimes folks will tell you, oh, don't try to ask too many questions, just let that person have that delusion. But you kind of have to assess that on a case-by-case basis. And so in addition to treatment, you do want to do reality testing with them, or ask questions challenging them about their delusions. Of course, in a non-threatening way, because you're not trying to get hurt. And symptoms can be experienced in many ways, such as beliefs, sensations, memory, thinking. So a lot of folks that are experiencing anxiety or depression, they might have issues with cognition, where they might report that their memory is not as good as it used to be, or they weren't as indecisive before, but now they just have so much difficulty making even simple decisions. And so it is important to make that distinction, so, especially in older patients. So is this dementia, or is this older person experiencing depression, anxiety, or mood symptoms? And it's not uncommon at all, actually, especially after folks retire and they don't have a structure in their day, for them to become depressed, and family members start thinking they have dementia because they're having memory problems, but it actually is depression. Now, diagnoses are just formal names that psychiatrists and other physicians use to identify disease states, and some of the ones that we already talked about: bipolar disorder, schizophrenia, then there's major depression, there's post-traumatic stress disorder that a lot of veterans have. A big concern that psychiatrists are faced with when treating patients in the community, especially with persistent severe mental illness, is the lack of insight. A lot of patients, so for example, a lot of the homeless population that you see using drugs and kind of just hanging out, the issue is that they feel that they don't need medications. They feel that they're doing just fine, and a lot of times they will be in treatment because they have been mandated by court, for example, if they're in the mental health court system, or if they came into contact with the criminal justice system. That's when they even consider taking medication. So at the Fulton County Jail, we have the competency restoration program, and you can't take a plea bargain if you're not competent to take a plea bargain. So for a lot of these folks, when they're out in the streets, they're not going to take any medication, but we have to go evaluate them and basically say, you are not found competent to stand trial, and so you will not get a court date unless you become competent, and so you have to come to the competency restoration program, and that's where they will take medications. We can't force medications in the jail. Medications can only be forced at the state hospital. But a lot of these folks that out on the street will not take medications will take medication when they're in jail because they're trying to get out. They want to be found competent so that they can take a plea bargain. Unfortunately, that is the same struggle that we have out in the community, because once these folks are out in the community and there are no consequences to not taking medications, they will likely not take them. And so it is important for them and their family members to be engaged with NAMI, for example, so that they can keep them on track, kind of show them that there is a possibility for them to actually lead a meaningful, productive life. And for that, for example, the peer-to-peer support group is excellent for that reason, because it gives them a goal to work towards. The next thing I want to talk about is signs and symptoms again. So for example, a young woman is observed on the side of the road having a panic attack due to fear of driving on the interstate. And an officer might observe extreme fear and sweating. So if the officer observes fear and sweating, are those signs or symptoms? Signs. Those are signs. And she might report experiencing a racing heart and shortness of breath when she's taken to the emergency room. And what are those? Are those signs or symptoms?
Symptoms.
That's right. Great. I'm a very smart audience. Okay. I have another quiz. So you are called to the home of a woman who's having suicidal thoughts. When you arrive, she states that she has had insomnia for a week and that she feels nervous. Insomnia and feeling nervous are symptoms. That's right. While you help her call her sister, who lives down the street, to take her to the ER, you note that her movements and speech are very slow. Slow movements and slow speech are So mental health exists on a continuum. So you can be at a point where you don't have any symptoms at all. Your mental illness is treated to a point where you don't have any symptoms and you don't have any impairments in your daily functioning. At that point, we say your mental illness is treated. However, that does not mean that you can stop taking your medications. It is just like your blood pressure is kept under control by taking antihypertensives or blood pressure medications. Your symptoms are being kept under control by the antipsychotic medications. So you can't stop taking it just because the symptoms went away. And so we have a whole spectrum from not experiencing any symptoms to folks that are in treatment, and we consider that they've been optimally treated but still experiencing significant symptoms to a point that they are repeatedly in contact with the criminal justice system or are civilly committed to a state hospital. Now, causes of mental illnesses are always a complex mixture of genetics and also environmental. These are sometimes referred to as the second hit. So it can be a major life stressor, an adverse or traumatic life experience. Next, I'm going to talk about the different types of treatments that are available. So first, which is my area of expertise, is medications. So we have antipsychotic medications, we have antidepressant medications, we have mood stabilizers, and just because you are on an antipsychotic medication or a family member is on an antipsychotic medication does not mean that they have schizophrenia. Does not even necessarily mean that they have psychosis, because it is not uncommon to use an antipsychotic medication to treat, for example, bipolar disorder. And sometimes we might use antipsychotic medications to help address any little break from reality that somebody with depression, with severe depression, might be experiencing. So just because they're on antipsychotic medication does not mean they are psychotic, because that is an important distinction, because sometimes patients might be reluctant to take these medications, stating that they're not psychotic, so why do they have to be on an antipsychotic medication? But it is important to understand that the antipsychotics are not only used to treat psychosis, they're used to treat depression, they're used to treat bipolar disorder as well, sometimes even in post-traumatic stress disorder. And then, of course, we have the antidepressants and the mood stabilizers. And a lot of times, when I'm treating bipolar disorder, I would rather use an antipsychotic medication over a mood stabilizing medication because of all the side effects that come with the mood stabilizing medication and all the blood work that is required. And a lot of folks in the community might not be able to keep up with, getting their blood levels drawn every couple of months. And with antipsychotic medication, another advantage we have is that it's safer to use antipsychotic medications in women of childbearing age rather than mood stabilizing medications that are known to cause birth defects. So these are things that are important to be aware of. So, before a psychiatrist starts your family member or you on a mood stabilizing medication, ask about other classes of medications that can be used instead. And the other form of treatment is psychotherapy. So for psychotherapy, you can have individual, group, and family therapy. Family therapy is important so that families understand how to deal with this new diagnosis in a family member and without making them feel estranged. And then there are psychosocial treatments, so psychoeducation, like what we're doing right now, social skills training, supported employment, peer specialists, and NAMI has a whole range of programs that assist with that, with the psychosocial aspect of treatment. And the reason I'm pointing all of this out is that treating a mental illness is a very holistic approach as opposed to other areas of medicine. It is not just prescribing a medication and adjusting the medication until the symptoms go away. Because if the other areas are not addressed, the patient will relapse or will not even take the medications in the first place. So you have to find them a place to stay. You have to educate the family on how to be supportive. You have to try to find them a job so they have meaning in their lives. So all those areas need to be addressed. In addition to, their medication, that is very important as well. Now, the most common side effects of medications, why folks will get off of their medications, would be disturbances in sleep, weight gain for women, and then the sexual side effects for men. These are the top 3 reasons why folks will stop taking medications. Now, your psychiatrist might or might not ask you specific questions as to why you don't like a particular medication. But if you do know that that is a reason a family member is stopped taking medications, then it's important to bring that up, because there are other medications that can be used. So, for example, there are weight-neutral antipsychotic medications. So Jade and Boulevard and Latuda are the ones that I like to use in folks that are very concerned about weight gain, because Zyprexa, for example, can cause you to gain a lot of weight, but it is ideal to use in certain cases when a patient is not eating, where that is a major concern. And so it's important to be upfront about what the side effects are that are causing you or a family member to skip medications or just avoid taking the medication altogether. For a lot of times, as in every area of medicine, a point is reached where you have to make a decision about whether the benefits of taking the medication outweighs the risk. And so, is it okay for this person to gain a few more pounds rather than be arrested again and end up in the state hospital for several years, as they have been in the past? So that is kind of a decision that has to be made sometimes, but of course involving the patient, involving the family. Another thing that I want to talk about is gene site testing. So previously in psychiatry, psychiatrists were a little bit limited into what they could do before they prescribed medications. It was kind of just, okay, let's just try this and see what happens. And then 2 months later, okay, that's not working, okay, let's try this. And so eventually patients just got frustrated and were like, I've tried this and that and it hasn't worked, I don't want to go back. But now we have gene site testing, which is excellent, because when you're in the doctor's office, your doctor can just do a cheek swab and then send that to the lab, and with that cheek swab, we know exactly what medications are more likely to work for you than not. And we're able to know what medications are likely to give you more side effects than not. And so in the past, when gene site testing first came out, people were very reluctant to order it because it seemed like there was a lot of cost associated with that. But more recently, insurances have started to cover that. And so it's important to be aware of that, so that when you go see your psychiatrist, you can ask for gene site testing, and your insurance will more likely than not cover it. And it will help save you time, your family member time, the psychiatrist's time as well. But even now in the medical world, for some reason, there's still a little bit of resistance to ordering the gene site testing because we want to save it as a last resort. But just the way science is advanced, there's no reason to do that, and especially if it's not cost prohibitive. And sometimes it has to come from the patient. That, hey, I know about gene site testing. Can you order that for me? Or what do I need to do to have that ordered? The importance of psychotherapy is that it can help individuals understand the things they're experiencing and form coping strategies to deal with it. And like we talked about, some examples of psychotherapy are individuals. Although your patient might be introverted and might do better at individual therapy. The group therapy helps them exchange coping skills, so your patient might not be very vocal during those sessions, but will definitely still benefit from engaging in that sort of therapy or learning from others, and maybe eventually even open up. And then, like we talked about, there are various forms of psychosocial treatment that are provided by NAMI, and so we have certified peer specialists, we have NAMI family to family, and then there's something called assertive community treatment. Now, assertive community treatment, a lot of programs in the Fulton County area that will serve Fulton County. For example, we have the Grady assertive community treatment program, and it's an ACT team, and basically what that means is that a group of health professionals, including a physician, will go out into the community and administer medications to folks that are very unlikely to come to clinic to take their medications, or very resistant to taking their medications, and kind of helping them with that. And they might have transportation issues or whatever it is. But there are ACT teams that serve Fulton County. The next thing I want to talk about is suicide. So Georgians at risk of suicide are the elderly, basically folks over age 65, middle-aged males, youth, ages 15 to 24, rural area residents, folks that have survived suicide, and some professionals, including dentists, law enforcement, and other first responders, military, and veterans. Now, people who consider suicide, we have a saying in the medical world that suicide is a case of mistaken identity, which basically means that when somebody attempts suicide, it usually is to teach somebody else a lesson. They're trying to make their families feel sorry for not paying them attention. And it is, a lot of times it is at a subconscious level, and it's important to address that in therapy and in treatment. But usually individuals who consider suicide are folks that cannot get control. They cannot stop their emotional pain, and they can't see any way out of their circumstances. And they cannot see things improving. They feel they cannot get attention or support. And sometimes they might even act impulsively, particularly in cases involving youth. Now, because we are talking about youth, it is important if you have an adolescent or a child that is depressed. Now, the black box warning for antidepressant medications do talk about the increased risk of suicide in adolescents. And what that is associated with is when and this is the theory behind that if somebody is depressed, they usually will not have the energy or the motivation to get up and end their lives. They might have had thoughts about it, but have not had the energy or motivation to act on those thoughts. And when you start them on the antidepressant medication, when they start feeling a little bit better, but not better to a point where the depression is resolved, they now have the energy and the motivation to actually carry out the suicidal plan that they had. So it is important to monitor anybody in your family, not just adolescents, but anybody that has recently been started on antidepressant medication. And a lot of antidepressant medications can be more activating than others. So for example, Prozac or Effexor, they can actually cause folks that engage in self-injurious behaviors to cut more. And so those are things that family members need to be aware of and watching out for. And at that point, the medication can be changed or addressed a different way. Now, the question that you need to ask, are you thinking of taking your life? Do you have a plan? Do you have access to firearms? And you have to take all threats seriously and seek immediate medical attention despite your personal beliefs. So we see that a lot in the emergency room, for example. There are folks with a diagnosis of borderline personality disorder. And there's just so much stigma associated with that diagnosis because every time that person makes a suicidal gesture or suicidal threat, medical professionals don't appear to take that as seriously as they should, because they're just seeing that as attention-seeking behavior. But the truth is that a lot of folks with borderline personality disorder will end up killing themselves, even if it's accidentally. They weren't really meaning to kill themselves. Maybe they were trying to get attention, but they will end up completing suicide. The next thing I want to talk about before I open up the floor to any kind of questions you might have is addictive disease or substance use disorders. So addiction is basically continued use despite negative consequences, and this engagement in substance use is disruptive to the individual's functioning, social and occupational functioning. Contrary to popular belief, addiction is a brain disease. There are disruptions in the dopamine reward pathway in these individuals. It is a chronic disorder, and it will require multiple strategies for intervention, and it can be treated, and the treatment is cost effective. If it's not treated, it's a primary progressive and often fatal disease. Examples of addictive disease or substance use disorders are alcohol use disorder, cannabis, cocaine use disorder, and more recently we've had the opioid epidemic. And that is usually, that was started off as treating, so the history behind that is in the hospitals they started telling physicians that pain is the sixth vital sign. And so physicians and nurses were over-treating pain when folks were admitted to the hospital, and now we've just switched to the other end of the spectrum where we don't even prescribe pain medications to folks that actually need them. But a lot of that has been induced by this change in the way the medical community thinks about pain. So some characteristics of addiction are problems relating to family and friends, difficulty sustaining long-term relationships, difficulty coping with stress, repeated unemployment, potentially recurrent criminal justice contacts, and denial of addiction. And a lot of times in mental health, we see co-occurring disorders where somebody has a mental illness but also is using substances. And that can be a little bit of a problematic area for providers, because if there is somebody that is, for example, doesn't have housing and is repeatedly coming to the emergency room hallucinating while he is under the influence of amphetamines, for example, the provider is very likely to diagnose that person with substance-induced or cocaine-induced psychosis or stimulant-induced psychosis and discharge them. But these folks are not going to go out and meet with a provider in the community to be followed up on. And so when you see somebody cross-sectionally like that, it is very difficult to make that distinction. Is this person hallucinating because of the substances he used, or does he have a primary mental illness like schizophrenia or bipolar disorder and is also using substances on top of that? And for that reason, we've kind of moved more towards treating. Even if you have an individual with hallucinations and their urine is positive for, say, cocaine or amphetamines, we are still required to treat that, just because we don't know if that is the result of the hallucination as a result of the substance, or if that person really has schizophrenia. Now, ideally, we want somebody to be off of substances for at least 4 weeks before we can make a primary diagnosis of schizophrenia, or make a primary diagnosis of bipolar disorder or primary mental illness. And I see that a lot in mental health court, where they want me to make a definite diagnosis, and I explain that to them that unless the substance use treatment is court mandated and this person has been off of substances for 4 weeks, I cannot make that primary diagnosis. But I still have to treat it. And it is estimated about 50% of individuals with mental illness also have a co-occurring addictive disease, but alcohol is the most commonly abused substance among individuals with a mental illness. And like I said, for treating addiction, yes, substance abuse treatment is important, and a lot of substances don't really have, so for example, for opiates, we have medication-assisted treatment. So the individual can be put on Suboxone, for example, or methadone. But there are a lot of substance use disorders for which we don't have medication-assisted treatment. However, that does not mean that we can't treat the symptoms of withdrawal. So for example, if somebody is using cocaine, just like somebody drinks a lot of coffee because they're both stimulants, but cocaine is obviously worse with illegal consequences. But when that person is withdrawing from cocaine, think about somebody that's withdrawing from caffeine, for example, and they're going to feel very fatigued. They're going to feel tired and sleepy, and they'll have low energy. And in that case, there are antidepressants that actually mimic what cocaine does, for example. So, for example, Wellbutrin, it's a weak stimulant. And so if you were to use Wellbutrin to treat somebody who is feeling depressed that is withdrawing from cocaine, that, in my opinion, makes a lot of sense because you are kind of addressing the same issues that they are having because of withdrawing from the cocaine. So there are other things that you can do to treat the symptoms, but not necessarily medication-assisted treatment like Suboxone or methadone, as we have for opiates. But yes, the treatment needs to be individualized, and then if they have mental illness in addition to the addiction, that needs to be addressed as well with medications. And staying in treatment for an adequate period of time is critical for treatment to be effective, and it needs to be very realistic. The goals need to be very realistic for somebody that has an issue with addiction, because for most folks that successfully become clean, they have taken several attempts to do so, and for long-term recovery at least. And it is an integrated system approach, treating both conditions that we talked about, but it's not just the medications, the counseling, peer support, and behavioral therapies that are key elements to effective treatment. So that ends what I wanted to talk about, and I want to open the floor to any questions, any specific questions you might have about.
Yes, do you believe culturally, or I personally believe that like all African American, not all, but a lot of us suffer from like the syndrome from slavery, from trying to make ends meet. Even though some of us are doing very, very well, I find a lot of us suffer from just trying to make ends meet, getting our kids through college, just paying the bills, trying to make it in a society where it's already goes against us. Do you think the medical or the psychiatric community acknowledges that, or they just push that to the side?
So that's a little bit of a conflicting question.
Oh, if the doctor, if you heard it and you can repeat the question that she asked?
Sure. So not so many words. She's asking, does the medical community recognize racial injustice in the past and how it affects individuals today that are Black? Is that right? Okay. And from my experience in the criminal justice system specifically, there is a wide disparity in the way minorities are treated, and minorities in general, and from their risk of getting arrested to their risk of getting the services that they need. And yes, I don't believe that the medical community turns a blind eye to that, because that is routinely discussed. But we all try to do the best that we can.
I'd like to comment on that question as well. And I'll begin with, we have 45 individuals that RSVP today. I've been lucky enough to be the president for the Atlanta Auburn affiliate since 2011. This is our second event, and we cannot get the community to understand that mental illness is simply an illness. And until we get the community to embrace the fact that it's an illness, it's like having diabetes, then we're doing ourselves injustice. So when we say injustice, we have to be careful when we continue, in my opinion, to want to put it on other people. We're doing it to ourselves because we refuse to accept it. When I first started doing NAMI, family to family, I met a very interesting individual, and I'll keep it brief. He said to me that he took his daughter to church, and that every church that he went to, they thought they could exorcise the demons out of her. And so I say that because culturally, instead of accepting it for what it is and moving forward and finding treatment and finding culturally sensitive treatment, we'll say it doesn't happen. We'll say that we enjoy the highs from some of the illnesses. We'll say that I'll self-medicate by taking, other things. And so again, until we're able to keep this conversation going, until it becomes cool to say I'm someone that simply has a chemical imbalance, when I'm dealing with my loved ones, I don't even say mental illness because I don't like the word. I simply say you have a chemical imbalance and what do you need from me and how are we gonna move forward? And I'll end by saying I recently heard the best song, and it's by Eminem and Rihanna, and it's called The Monster Under My Bed. I play that song over and over and over, and I'm becoming a little more encouraged by saying if the rap community can begin to embrace what this is and make it cool and make songs about it, we won't have a room that only has this amount of individuals in it.
Okay, I agree. As I was driving here, I heard a song from the Ghetto Boys. I don't know if you remember those people.
Mm-hmm.
They also made a song called Minds Playing Tricks on Me.
Correct.
So the community
Correct.
does know that. Maybe we're a little delusional. The community does it. I got two sides of my family. Some of them are hard workers and some of them are addicted. You know what I'm saying? I mean, two things I come from. My mother and father were black tar heroin users. I chose not to do that. But I just find that. I find that families in different cultures, people band together to help each other out. You know what I'm saying? And I find the cultures that band together to help you out, they help you out of these issues.
Correct.
The resources, money,
Correct.
to help you.
Correct.
You know what I'm saying? So I'm not trying to push it on somebody else, but I know these are signs and symptoms, like she said, that we have been dealing with for years.
Correct.
But some of us don't know how to make it out of that.
Correct.
I just happen to be, I'm just a go-getter.
Correct.
And I decided that, I don't want to be like this man, I don't want to be like this woman. Some people don't have that grit, that gumption.
And that's NAMI, and that's why we're doing this today, because the good thing about NAMI is you get trained for free. Any training you want, I call A to Z on mental illness. You get linked to free resources. All it requires is your time. And so for the Atlanta Auburn affiliate, we have lots of individuals on the side that has the chemical imbalance. We do not have individuals on the family support side that want to actively participate in NAMI. And so we have to, in my opinion, we have to do better, because to get the word out, to say this is free, this is what you do, to say if your loved one gets caught up in the justice system, I'll walk you through how to do it because I successfully did it. We just have to get better at saying, it's going to take my time, I'm going to give my time, and then one teach one, one teach one, one teach one.
And I'd just like to add, my name is Casey, I'm a sociologist by trade, and what our community has done has normalized the struggle. And I think to Ms. Joanne's point, those of us who understand that this struggle is not normal, nor is it behavior that we have to continue just because we've learned behavior from our forefathers and foremothers. It takes those of us who understand the difference to say, hey, it is not okay for you to feel like you have to be burnt out to say that you worked hard. And it just requires us to speak up and show folks a different way to find balance in their life. And if balance includes getting professional help or medication, if there's a chemical imbalance happening, then that's what we do. But I think so many times we've just learned how to grind so hard, and the way that we grind, we've normalized it, and we think that it's, just working hard or doing what we have to do to make ends meet. when it's just learned behavior that we have to unlearn, and that just requires us saying, hey, there's a better way to do it, and let's try together to find that way.
I want to also add, I was several years ago, Morehouse College had an event for the Black Psychologists of America, the annual event, and there were several psychologists that dealt with the struggle of slavery. And I'm sure people know about the Willie Lynch letters and everything. So these are signs and symptoms where, just to be brief, you take one, the house slave and the field slave, and you turn them against the other. But his words was, if you follow these practices, you have them under control for 300 years. So until you break that cycle, my great-grandmother was raped by a slave owner. Slave owner. But even in my family, both my parents are college graduates, and my father actually has a master's in psychology, but we never talked about depression. We never discussed because of personal issues. So a lot of times these things are ingrained. You can get out of them, but you got to get beyond your environment. You got to go beyond that. And NAMI is a great source, like you said, it's free, but it has to be exposed in the community. NAMI has actually saved me from just staying in the bed and not doing anything and being a leader in NAMI. So if it wasn't for NAMI, I probably would not be where I'm at now.
Can I share something? I just want to say, what I have noticed in the hip hop community. So the hip hop community is not black. It's not the ghetto America. It's America, period. It's actually the world, because hip hop is the world. But what I've noticed is basically mental illness in hip hop, and no one knows how to embrace it other than to like it, to laugh at it, to encourage it. And when you encourage it, you're only doing nothing but hurting the person, because you're encouraging the bad behaviors or the interesting behaviors, not really bad, but the interesting behaviors that come from that person's illness. And so therefore, they actually think it's interesting because you're following them on Instagram, you're liking their music, you're buying their music, you're buying their products, you're going to the concerts, and their behaviors are erratic. You know what I mean? They're getting drunk and high, but that's because they don't know how to actually cope with the situation right now. So therefore, their behaviors are just off the hook. Sex with everyone, anything they can get their hands on, or if not that, they're just really, really violent. And everyone is just like, oh wow, follow that person because they're cool. Follow that person because they had the latest trend and the latest fad. It's not cool because they're mentally ill. And the hip hop community does not know how to actually, again, embrace it. And they don't talk about it. It's even the situation with Kanye West when he was going through his episodes, and no one actually embraced it. No one said anything further about it though. It was kind of like pushed under the rug, and that's Kanye West, or he's he's a billionaire or millionaire, whatever he is. So, but it is what it is. And that's it. He's married, Kim Kardashian, so we're gonna let it go. And that's it. But they should have been, talking more about his situation in his episodes. He should have actually talked more about his episodes. You're visiting the White House. Do we take that seriously or not seriously? Was that an episode that you had, or was that not an episode? You know what I'm saying? No one spoke about it though. Again, this is the hip hop community. We're buying your products, we're buying your Adidas, we're buying your shoes, your clothes, everything. Basically, we're purchasing your merchandise, giving you money, our money. You know what I'm saying? But no one's not talking about anything. And it's really interesting. And also, I will say this though, Rihanna and Eminem have actually touched on a song about mental illness called Something in My Closet. Something under my bed. That's really, really interesting though. The person or the monster under my bed. Yeah. That's pretty hot though. It's a hot song. You know what I mean? It's a catchy song. It's really, really cool. And in that song, they actually do talk about mental illness. It's really, really interesting. So yeah.
Well, speak.
I wanted to know, I have a friend that was recently diagnosed with bipolar depression. I don't understand what the difference is of depression, bipolar, and now put the two words together. Can you kind of tell me what that is?
Okay. Okay. In not so many words, bipolar disorder, we diagnose somebody with bipolar disorder when they've had at least one manic episode. So manic episode consists of at least 4 days of experiencing mania. And manic symptoms include being reckless, engaging in reckless sexual activity, reckless spending behavior, going nights without sleeping, having racing thoughts, having pressured speech to the point that it is difficult to interrupt you, feeling like you are flying high, that you are unbeatable, unstoppable, and to the point where it affects your functioning. Because when you ask folks about these symptoms, they're going to say yes to everything. That yes, I've experienced that at least one time in my life. But the follow-up questions you have to ask, were you using any kind of stimulants at that time? Because cocaine can do that. Sometimes cannabis can do that as well. Really speed people up, or using amphetamines or Adderall. And then the other question you have to ask is that how did it affect your functioning? Were you still going to work? Were you still, functioning socially? And if they were functioning okay, then it's likely not bipolar disorder. That's called hypomania, but that's different. Now, with bipolar disorder, coming back to that, you've had to have at least one manic episode for a diagnosis of bipolar disorder. Now, with bipolar disorder, a bipolar disorder is a cycling disorder, which basically means that you will have a manic episode, and then even without treatment, it will resolve. A couple of months later, you'll have another manic episode, and then it will resolve over several weeks or several months. The issue with that is because a lot of patients will ask them, why do I need to be on medications if it's going to resolve on its own anyways? The problem with that is every time you have a manic episode, it affects your cognition. In addition to that, it affects your functioning. So can you imagine if you had 2 or 3 manic episodes a year, and you went ahead and you bought a $500,000 car, and you didn't have the money to pay for it. You went and you gambled everything, all of your savings. Like, can you see how that could be detrimental to somebody? And so that's why it is important to prevent those episodes from happening. Now, when somebody has bipolar depression, basically what they have is that in between the manic episodes, they have episodes of major depression. And major depression is basically 2 weeks of not being able to get out of bed, feeling guilty, feeling hopeless, not having any energy, having thoughts of suicide. So basically they're having extreme highs and they're having extreme lows. And the treatment for bipolar depression is just a little bit different from just bipolar disorder, because we have to address the depression as well. The tricky part to that, though, is when we treat depression, sometimes folks will cycle into mania, because if you're treating a low, if you hit too high, you might make the person manic again. So it's important to follow up routinely with them, at least when you're initially managing their medications, until you've found the perfect combination of medications they need to be on.
So if I'm seeing, because I feel like I am seeing that more mania than I was seeing before.
Okay.
And they're taking something called like fluoxetine or something of that nature. Do you think that's a good?
Is that the only medication?
That's the only.
Okay, that's not a good idea, because fluoxetine is Prozac. It's an antidepressant. When you have somebody with bipolar disorder, you can't have them on just an antidepressant because they will cycle into mania. You need to have something to stabilize the mood and then add an antidepressant. Either you can do that. So either she can be on a mood stabilizer plus an antidepressant, or she needs to be on an antipsychotic medication. Do you want to write that down?
I do. Thank you very much.
Yeah, of course.
I have a question. Is
Yeah.
the bipolar disorder, is that, the symptoms long-term?
Yeah, that's a lifelong illness.
It is a
They need to be on medications for the rest of their lives.
I got a statement I've done in our Voices at McIntosh Trail, and actually this year, I wasn't I was at the graduation of peer-to-peer, I'm peer-to-peer certified.
Okay.
And I can see the growth there. I'm not sure if they're still doing it, because in the day center, you know, you just can't do the same thing over and over, dealing with the same people. So I'm just, I don't know if you know what's going on now.
So
Yeah.
I just started there this week. But that's one of the reasons, you know, I picked them because their involvement with the mental health court, especially in Henry
Okay.
County, is very, very strong. And, you know, that is my area of expertise. That's where my heart is, the diversion programs, trying to move our patients away from the jail and getting them help. But I do know that they have their own internal programs that are very, very good.
And Kenya Phillips, she's the one over the programs, and she lives in that area. She's the one who helped me. That's a good person to talk to if you get involved with that stuff in the NAMI Georgia office.
Yeah, of course.
Yeah.
Thank you.
Sure.
Question. The Fulton County, Fulton County Competency Restoration Program,
Yes.
the diversion program, does that decrease the time of the persons, or how does that really work?
So there are mixed opinions on that. What I've noticed it's helped with the most is waiting time to go to Georgia Regional. Georgia Regional never has any beds. And then you have somebody with a not very serious felony just waiting in jail for several months because there's no competency restoration program. So Emory University actually started this program about 10 years ago. And so the forensic fellows are the ones that run it. And we restore competency in the jail. And for the folks that we're not able to restore competency, we're unwilling to take medications no matter what we've done, no matter how many snacks we've promised, they end up going to the state hospital, unfortunately. But it is a pretty successful program.
What program was that?
The Fulton County Jail Competency Restoration Program. It's only the jail for the males, though.
For males?
Yes, and currently Fulton County is under a lawsuit because they're trying to get the competency restoration program over for the women at Union City, and which will be perfect, but.
I had another question for you. I understand that clozapine
Before you
is,
go, this is
one
going
of
to be
the
the
top
last question because we have to
medications, right?
move forward. Okay.
Excuse me?
I was saying this, you'll be the last question because we have to move forward.
Oh, okay. So clozapine,
Yes.
I'm sure you're familiar with that.
Mhm.
I understand that that's kind of like the granddaddy of psychiatric medications. Once a person has been taking that for a period of time and they decide not to take it anymore, where do they go from that? Once it's out of their system and they're obviously not okay anymore, where do you go from here?
How long have they been off of the medication?
A year, 18 months?
About 18 months. Have they been on any long-acting injectable in the past?
No.
Okay.
It's clozapine and nothing.
Okay, they've not been on any other
Nothing.
antipsychotic medication?
Nothing.
Okay.
Where do you go from here?
So clozapine is a good medication. I have a lot of respect for it. The only issue with it is that when you're realistic about the population that we're treating, it is almost impossible for them to keep up with the blood work. It is almost impossible for them to keep up with the monitoring.
That wasn't a problem. The monitoring, the blood work was not the problem. I understand all of that. I mean, I've been through it, so I'm asking from experience. Right now, the individual needs to be on medication. Where do you go from here?
Does
Because
the individual feel? Go
I
ahead.
find that the physician is at a loss.
Okay, so we can't force medications on anybody. I don't know if you perceive that as a loss, but that is the reality.
I understand
Unless
that.
they are involved, unfortunately, unless if they're involved with the criminal justice system, and even then, even when they're incarcerated, we can't force medications on them. Unless they're a danger to themselves or others. They have to demonstrate that, and that's imminent danger. That's not enough for families to come and say, you know, this person has been doing this, this, and this, right? You can have them civilly committed to a state hospital where they will receive forced medications. But just taking them to a clinic to get medications while they don't want them will be very difficult, if
Where
not
would the
impossible.
doctor start? once they've been on clozapine, where would the doctor start with medication?
If I were to work with this patient who's been off of medications for 18 months, I would probably start with Risperdal and move them to a long-acting injectable called Invega. Now we have Invega Trinza, which you can administer once every 3 months, and it works very well for folks that don't want to keep up with that frequent monitoring, or might not even, it might be hard to locate them in the community because they're homeless.
So there is a possibility, there is another medication.
There are several other medications that should have been tried before clozapine.
Okay. Right now I'm going, are we going back to clozapine? Or,
He or she does not have to go back to clozapine.
so once they're off of clozapine, then it's like a blank slate, and then you start back.
Yes, it will have to be titrated up just because of all the side effects of clozapine.
That's what I needed. Thank you.
Another place to start, if they didn't want to take clozapine for whatever reason, is Zyprexa, because Zyprexa is the closest. Its generic name is olanzapine. And just like the name sounds familiar, they're actually related drugs. And so if there's any issues with clozapine, but you know that the person did well on clozapine, but doesn't want to deal with all the blood monitoring, maybe that's one of the reasons that person stopped taking it. Do you know why the person stopped taking the clozapine? What is the reason?
Because of depression, they lost their therapist who put them into depression, so they decided not to do anything, and
I see.
that was it.
Now, is this
So,
person,
but
Go ahead.
clozapine, as you say, is a very, has a lot of side effects, and that person did suffer the side effects from the clozapine, and that kind of made them not want to take it anymore.
okay,
And
if that's the case, clozapine is, for a reason, it's a last resort medication, just because of all the side effects that go with it. So if we're starting clean slate, I would rather see this patient on a long-acting injectable, which is actually our first line of treatment for somebody that's out in the community with schizophrenia or even bipolar disorder now. But yeah, long-acting injectable would be the way to go. And to do that, either start them on oral Risperdal or oral Invega and transition them to Invega.
But they wouldn't necessarily have to go back to the clozapine.
I don't believe so.
Okay.
Sure.
Thank you, Dr. Sardin.
Yeah, of course. Thank you for having me.
So we are going to move forward to our next activity. We're going to get set up and going to take a short break, and then we'll come back. All right. Thanks, everybody.
Affected by mental illness will find hope, help, and acceptance. So part of the mission for the Atlanta Auburn affiliate is to educate individuals in our community about mental illness, to improve the resources and services and knowledge, and to help reduce the stigma that is oftentimes discussed in our community. And so that mission is humongous when I look at it, because the education that has to be done in the community, being able to continue this conversation, is something that I hope we all walk away with today. Part of the goal for the affiliate is to promote public policies that expand services and improve treatment for our loved ones. And so it's important when we're looking at public policy that we're taking a holistic approach, so that everyone that is a person of color will be included in that public policy process. And again, part of the goal is to continue to keep our community engaged. So our objectives today that I hope you walk away with is to, again, continue to talk about mental illness, find innovative solutions to address the lack of active membership that we have for the Atlanta Auburn affiliate, and to increase the signature programs that we're able to offer. NAMI has a plethora of signature programs, and our affiliate right now is only able to offer 2 because of the training that's involved in the time frame. We offer family to family, and I call that the circle of support for the loved one that is experiencing the illness.
Excuse me.
It's on.
There we go.
Oh, okay. I was like getting happy. I was like, yeah, you're seeing what I'm saying.
I'm old fashioned.
You're like, oh, but I'm like, huh? And so again, we should be able to offer every signature program that NAMI has. But again, only being able to offer the family to family, we offer it twice a month. We're located at the Center for Health and Rehabilitation. It's offered the 2nd and 4th Tuesday. Parking is free. Last Tuesday, and I have to laugh to keep myself encouraged, there was one individual that showed up. When she came through the door, I ran and hugged her. Because for me, I'm oftentimes juggling my 9 to 5, and I'm convincing them that I need to duck out early because there's something else that I'm passionate about and I do on the other side. And so I had another position up in Tucker, and finally there were so many complaints about me always leaving that they figured out a way to get rid of me. So now things are better. I'm working with the state. And, they understand because I came right in saying I'm very passionate about mental illness. When I have individuals that are my customers, I can also bring that to the table for them, even though that's not necessarily part of my job description. The other thing that we do really, really well is we have connections. And I'm really lucky enough to have 2 individuals that facilitate our connection groups. And Jade Royale is also in our leadership team. Jade, could you stand up? And she is over the programs and services. And then our newest member is Howard Ferguson, who has just been a tremendous asset. I'm so glad we were able to get him from Gwinnett because he has hit the ground running on our marketing side. And so again, I'm hoping that you guys will go to our website, that you'll become active members, and that you'll get trained in the signature programs, because Fulton County actually has a grant, and the grant deals with the younger population. NAMI Northside is able to come to the table and participate with that grant. On the south side, we are not, because again, we don't have anyone that is able to address the needs of the young people. You have a question?
Question / quick comment. So I was a part of NAMI Northside, and when I paid my annual dues, I switched to this chapter.
Yes.
So I'm not sure if you guys received that, but I'm peer-to-peer certified and also youth mental health first aid licensed and certified to provide instruction as well. So I don't know if that would be helpful to this affiliate or not.
Well, be helpful. Do you see my big smile?
Hello? Peer-to-peer.
I'm greedy. I think as a community, we should be able to offer every program. And so when we give you the goodie bags, we just put a couple of the signature programs in the bag. But if you go to our website or if you go to the NAMI Georgia website, you're going to see it's an awesome amount of programs that, again, it just takes your time. And the good thing about NAMI is a lot of times they offer it like a Friday, a Saturday, and a Sunday. I was very vocal and I said, listen, I just can't keep calling out sick on a Friday. They're getting like, where is she going? She's always sick on Friday. So now they're making sure that they offer them on an all-day Saturday and an all-day Sunday. NAMI Georgia gives you great lunches and the snacks out of die for. So I'm trying to encourage you to just participate in that. Oh, okay. Gotta turn the lights off and you're gonna be able to see what I'm doing. Okay, the good thing that we're going to touch on today is, and this is going to be an active group, is I need to kind of get a feel for what does mental illness mean to you guys? What does it mean to you as a community? So we're gonna hand out her. Hand out. Use the paper, follow Jade. Yes. Yes. Can you just hand them out? Okay. So we're gonna get you to just scribble whatever your thoughts are. There's no right, there's no wrong. What we're gonna do as an affiliate is we're gonna compile all this information so we can see where do we need to hit the ground running. What is it that we're missing as an affiliate so that, just for the different sections of the table, please, ladies. And again, no right or wrong. We're not interested in spelling. If you're a great speller, terrific. If you're not, that's okay. But again, the question is, what does mental illness mean to you, and what does it mean as a community? And so I'm going to take a little brief pause, and we're all going to participate in this question. So anybody sitting over to my right, please join the table where there's a board, and let's just spend about 10 to 15 minutes while we're eating our lunch, really just coming up with some answers to that question. What does mental illness look like to me? What does it look like to us as a community? So we're going to take a pause here. We're going to do 15 minutes. We're going to make sure everybody has an opportunity. Okay, I'm going to come.
Mental health means to me, we put building a balance in life and work, recovery, inability to manage or function daily living, suicide, depression, state of mind that determines your functionability, and then for mental health in the community, what it means to us in the community, denial, overcoming stigmas, years behind other cultures, beliefs, different beliefs, holistic mind, body, and spirit, suicide, and depression.
Excellent, thank you. Group 2?
Okay, we have balance, liberty, recovery, freedom, love, acceptance, self-care, uniting, peace, positivity, drama, trauma, community, no more silence, a way of life. It is cool, courage.
Thank you.
For our group, we, for the first part, said that mental illness looks a little like difficulty functioning, that there's some challenging behavior that others may or may not be able to accept, unable to concentrate. Some of those experiencing mental illness may become homeless or find themselves living in the streets. There's loss of appetite, suicidal thoughts, not sleeping or sleeping too much, which then can cause other issues such as low motivation, low energy. When you don't have enough energy or motivation, you may find yourself not bathing. It causes fear in the community.
I'll go first. I felt very free.
Agree.
Yes. Anyone else?
Just glad that we can talk about it.
Yes.
We don't talk about
Yes.
mental health. It's a secret.
Yes.
So that's good that we are all here and are able to have a discussion about it.
Yes.
I love how you said the secret. I like that. No transparency. You know, we're talking about to ourselves out in our culture. We have what goes on in our house stays in our
Yes.
house.
Yes.
Which is the biggest myth and lie that we should continue perpetuating. We should have liberty and freedom to speak and have our voice be heard.
Yes.
And not shut down.
Yes.
And put in a box.
Yes.
We'd be better off as a community.
Exactly. Exactly. Howard?
Yeah, and it's all relatability, because even though when you're in a deep depression, you feel like it's only you. Like you put this on there, we all have something in common in
Yes.
humanity. And as a Christian, that is a lack of, most depression is because you don't feel love. If you don't feel connection and love, you should be depressed. You know?
For me, it's talking about breaking a generational gap, because I have children that, well, adult children who are diagnosed with a mental disability, but knowing that I can break those chains, that we no longer have to live in those slave mentalities that we just would set in the house, stays in the house, where we can bring up the awareness not only for ourselves, but for our melanated brothers and sisters.
Yes. Yes. Anyone else? Okay, thank you. So I'm going to hit the pause button on my presentation for a minute because we're lucky enough to have 3 individuals that are going to share with you their journey. And so NAMI trains, and it's called In Your Own Voice. So we're going to start first with Jade, who is my right-hand person when it comes to doing stuff with the affiliate. So I want everybody to give Jade Royal a round of applause. You can do it. It's all you. Coming down here so I can record.
Can you guys hear me?
Yes.
Okay, so I really don't like using the mic, to be honest with you. So as long as you can hear me, I'm going to have to read off a little bit of mine. That's the funny thing about mental illness. But I don't see it as a mental illness. I see it as a blessing. I see it as a gift. So let me officially introduce myself. I am born Aisha Brown. That is my name by birth. Born March 6th. I won't give the year. I'm a cougar, yes. So born March 6th. I'm Aisha Brown. And NAMI has been really good to me. I've been with them for 9 years. I'm originally I'm the Jersey Philly girl, and by way of San Francisco. So how I got involved with NAMI, well, originally I started in Philly. I started with NAMI. NAMI has a Philly affiliate. And so I went there for some issues in regards to my family, because there was just, my children had been traumatized, but I'll go into the next with that. So I moved to San Francisco. I said, okay, my kids have graduated, it's time for mom to do her. So I moved to California, not knowing that I was going to get the call that I was going to have to come to Atlanta for my daughter. That was the original issue. She had mental health issues, and she also had seizures. And so she was staying with her father's side of the family, and it was just treating her emotionally and mentally wrong. So I said, okay, I'm going to be the Wonder Woman mother that I am. And I came to Atlanta, not knowing that I was going to be here 9 years later. So with that being said, with all of that, you know how even if you're not diagnosed or not, we've all been through something in our lives. Let me see a hand. We've all been through it all, right? So the Creator, or the universe, or God, however you want to call it, has a way of shutting you down when you don't take care of yourself. So that's what the universe did. Shut me down. And then I start just learning and knowing more of keeping that secret that our families tend to do, keep those secrets, keep silent, and didn't speak about anything. So it brought me down. So as far as what happened, I feel like I've always been the unique type of person. I've never seen myself as everyone else. I'm an only child. I'm a military baby, okay? So I've always seen myself as unique, not different, not strange, unique. So my unique journey, as I call it, I was 3 years old when I first got molested. And I was molested by a friend of the family. He actually was a cab driver. He was the cab driver that had befriended my mother. And when my mother needed to go to work because she didn't have money at that time to send me to any child care or any daycares, anything like that, she had to go to work to provide, because even though I was a military brat or military baby, Dad went off and did what he did while Mom was the full-time provider. So as she went to work, he would take me to the daycare. And you know, when you're 3 years old, from 3 to 7, you don't know. You don't really know kind of what's right or wrong. You don't know that I didn't know that what he was doing was wrong. So I just accepted it, not knowing. So from 3 to 7, it was okay. And for the longest time, as I got older, I blamed myself for not saying anything. But again, I came from a family that what's done, it stays in the house. Like most black families. And as I got older, I had a variety of bad relationships and didn't know how to stand up for myself because I was very shy. I didn't speak about a lot of things. I kept so much in until it took for me to have my children. And when I tell you, when I had my children, I started opening and running my mouth. That's what I did, and that was the beginning of my journey and my recovery. I am dual diagnosed. I'm a recovering addict, meaning I have used crack and cocaine. I've been clean for 12 years. Thank you, universe. I've been clean for 12 years. I'm also diagnosed with that, with major depression, PTSD, schizoaffective disorder, where like the doctor said, I do hear voices that no one else hears from time to time, and I do see things that people don't see. And that's very hard when you're in today's society where they use that word that I don't like, crazy, okay? Because I'm not crazy, I'm just unique. It's a blessing. It's not, it's for me, I don't see it as a curse. It's a blessing because it's my gift that I can give to other people to let them know that my experience, it doesn't define me. My mental illness or mental disorder doesn't define me, because if looking at me, you would never guess that I have mental illness, but you would never know that I go through it daily, okay? Also with that depression, I have PTSD. So with the PTSD, when I became an adult, I got raped in my 20s from a man I have, till this day, his name is fresh in my mind. Though I don't think about it necessarily, but it's just, if you ask me, I would say his name. His name is Israel Santiago. I have no idea who that man is. And so with that, with having a mental disorder, yes, I was one of those product children that when you went to church, they put you in that circle and they prayed for you because they thought that you were possessed. But I wasn't. I was unique. So I try to teach my adult children, even now, because they are diagnosed as well. And I have a mother who's in her 80s, who it took for her to get diagnosed with dementia to now get diagnosed. She's actually 83, who also, with the dementia, is associated with having a mental issue, depression, and PTSD. Because again, our families, we don't talk about these things. My mother, it took her to have her dementia to tell me that she was molested by a family member. It took me to be in my adult years to tell her, Mom, I got molested and raped, because I felt shame, because I felt like if I told her growing up that I was gonna get in trouble. So our bond is, I believe that me and my mother, we've always had a bond, but I feel like it took our bond currently to be the way that it is, because when she's up, I'm up. When she's down, I'm down, I have to be honest. I use crack and cocaine to that hurt, that pain, that shame, that fear. I've been homeless also. I've been in a shelter. I've lived on the street. I've been under the bridge. But you would never know it because I felt like I needed to present myself in a different way. And it is sad to me, in my opinion, that when you go to different, and not NAMI, but when I've been to other different places, that even when you go into these mental health places, there's stigma with that. For me, I can speak on my experience. I can't speak for anybody else. But there's so much stigma. I've had to fight really hard to get where I'm at. And I'm not where I'm at yet, but I know the universe knows He has so much more for me. I use my spirituality as first and foremost in everything that I do. My spirituality, if I didn't have spirituality for me, I probably would not be sitting up here now talking to you guys. So spirituality plays a very smart place in my heart, and just sharing, and this is my life. Like, I have a full-time job. They don't even know I live with a mental illness because of just everything that I hear them say. They're very homophobic about mental illness. and they just, I know that I can't change individuals' minds, but I know that I can choose in what direction that I go. So I just want to just share this few opportunity and kind of round it up by saying what's next for me or what's currently happening now. Well, I work full-time, yes. I have a business, yes. Actually, I am part owner, part business in my significant other. We have a business. I go out and speak with NAMI, but outside of NAMI as well. I'm not ashamed of who I am. I'm not ashamed of no more where I've come from. Let me also say, I'm an ex-felon. You would never even know it because that's my past. My past is exactly that, my past. And though, again, I cannot change how people feel about me, if you can't just accept me for who I am, I'm okay with that today. I'm okay with with sobriety. I'm okay with being who I am. I'm okay with the mistakes that I made. I'm imperfectly me. So I look forward to the continued journey with NAMI and also on my own with the business and taking it as far as I can. Thank you.
Well, supposed to ask any questions? We'll do questions at the end. We'll just run everybody. And then collectively, we'll let you all ask. I'll bring the whole group back up. So next we have our next, Howard, what can I say about you coming from Gwinnett?
I'm happy.
Woo, this was the best thing because trying to find an African-American male that will not only speak about it, but live his truth, Howard Ferguson, everybody. Woo!
How's everybody doing today?
All right.
Good, good. I've been kind of nervous too as far as a guy, because most of the time when I do things, I'm dealing around women, and it's sometimes hard, as you know, for guys to open up. That's our big problem, just talking everything. But basically, getting on our system, what happened to me was, I was, at 13 years old, I was told by mine I was a mistake. You know, the black community, you know, as you said, you know, we don't talk about things, and my parents were always like kids to be seen and not heard. So I didn't really learn about my life. So I was kind of an adult. You go through life and figure things out. And one of the first things I figured out was, and through talking, my mother had 4 miscarriages, and they adopted my oldest sister. So when they adopted my older sister, the day they brought my sister home, my mother was pregnant with me. Now the firstborn child is, like in the Bible, is supposed to get all the goodies. But I ended up getting the bad thing. So my mother was diagnosed, wasn't diagnosed, but she had postpartum depression. That wasn't talked about in the 60s. She couldn't even milk me. I mean, all these things you learn years later. And even when I was a little kid, my mother would say, you know, you're a hypochondriac, because her father was one. So I'm going through life confused. How come I ain't treated like everybody else? And then a year later, my sister's born, so I'm the middle child. So I went through a lot of life just feeling like being ignored. But on the flip side of that was, my mother was a Christian and my father was more of an academic. So he retired a major in the 60s. That was a big deal for a black man. Also, too, after he got his bachelor's in biology, he got his master's in psychology. So he was actually a counselor. So the word depression was never talked about. But the conflict was, I learned later on, is that we lived in a great neighborhood, 12-room house, and the kids would yell to us, and I used to say, that I felt like I was born with a silver spoon in my mouth. But how come I don't feel like everybody else said that? So one of the things that as a kid, it was really weird, you know, especially being a Christian. My mother would say, because my father's school teacher, my dad's bring these books home, and we got demons in the house. And I'm like, as a kid, I'm like, you know, it's kind of going over my head, you know. But as I got older, I started enjoying watching scary movies, Twilight Zone, all that kind of stuff, and everything. And I don't know if anybody's heard of like lucid dreaming, or heard of sleep paralysis. my sister had that too. So I had experience where, when I was probably 8, 9 years old, that I was, sometimes the kids, you want to go to the bathroom, you had this dream where something happened and stuff. And I had a dream that there was this pillow over my face. And it was pressure, pressure, pressure. And the only thing I could think of as a Christian was like to say God's name. And it took me like 4 times for that happened. I woke up with just in a sweat. But at the same time, being a middle child and everything, I didn't know who to talk to about it because I really didn't matter. So I went through a lot of things going in my life where I just kept to myself. And as I became a teenager, I was kind of like a split personality in a sense. I could be outside and be happy and go lucky and be in church, but inside, all I got is my problems. So I got to the point where I started my teenage years, I started having suicidal thoughts and everything like that. But when in the family setting, I'm funny, Howard, and my nickname was the human garbage disposal because I ate. And see, that's where I would deal with my problems. But my family was just making fun of me, just thinking I just had an eating problem, But it got to the point where, as I think I talked to somebody about today, the amygdala is the part of the brain where you have pain. But it's the exact same part of the brain we have emotional pain. So if you got shot, you got beat up or something, they could rush you to the doctor, they could patch you up, give you some morphine or maybe some illegal drugs, feel better. But there's no way to shut off the emotional pain. You feel hopeless, you feel depressed. There's no button to press or something, especially being a young person, no drug, you don't tell anybody. So the thing about it, that pain can be so bad that a person in their right mind will want to kill themselves. But with me not being able to talk to anybody, and also having, one thing I forgot to tell you was that, I don't know where this came from, but the deed to my father's house in 57, if we lived in a 12-room house, very big house, in a very good neighborhood, that said this house would be sold to no Negroes. And the other thing I learned as I got older was that when they did remodeling, they found religious relics in our house. So I don't know exactly where it came from, but we did have, from my point of view, it wasn't schizophrenia, we did have like demons in our house. But if you watch these shows on TV, they always go for like the young people. They don't really, they're the ones that have the contact and everything. So I start going from suicidal thoughts, and it got so overwhelming, I felt like if you think about something long enough, you do it. So I elevated that, I took that anger out to where it was coming from. So I started having homicidal thoughts. I actually wanted to kill my parents. But when I'm in public, I'm Mr. Happy Howard and joking and stuff like that, but by myself, I had nobody to deal with. And this is in the 70s now. So once it got to the point where it's like, I know I didn't want to kill my parents, I was bipolar, I couldn't get away with it anyway. I'm watching Columbo, watching all these murder shows, and smart people can't get away with doing it. So I know I wasn't going to try to do it. So it got to the point where that it elevated to, like you see today, these mass shootings. I started having ideas of going to McDonald's, shooting people and stuff. But it was all effort to get rid of the pain. I wasn't on drugs, that kind of stuff. And then later I got into love with music. And being bipolar, which I didn't know at the time, I started with the simple R&B, the disco music, and one of our Christian pastors said, stay away from that sexual music, that kind of stuff. So I gradually went from our black music to pop music, to rock music, to heavy metal, to like punk music. And so I got really deep into that. So to the point where AC/DC, Black Sabbath, all that kind of stuff, that was in my head. And even when I decided to get baptized as a Christian, I realized I didn't let that music go. And even the experience when my mother went in my room one time and saw this weird Christian family and saw all this crazy stuff, we tried to take it outside in the alley where Chicago has alleys and stuff, and we tried to burn one of the records and it wouldn't burn. And I told my friends, I said, I was addicted. Even as a teenager, I felt I was addicted to music. Even though I didn't know, being sheltered, I didn't know what that really meant. I just knew that I had to have it. So I brought that album back in the house, And so it got to the point where even after I got baptized, I never let that music go. And 6 months later, I had this like mental attack, thinking that I was going to, I was a kid thinking I'm going to battle the devil, that kind of stuff. And I got this incredible pain in my head. It was unbelievable pain. And because of Latin music stuff, I had a thought. This is like pray to Satan. And as soon as I did that, it went away. So, long story short, I went through a lot of life ups and downs. I did real estate, I got married and stuff, and bipolar. I made money, I lost money. My life was just up and down and everything like that. And so, you know, you get tired of getting tired, but I didn't have any hope. Even though I was going to church and all these other things, I was always felt alone. So basically, what happened to me was, I finally, about 23, I finally got a good job. I worked for an electric company. And I actually saw on TV, even though my father was a psychologist, we never talked about depression in the house, which was really kind of crazy. He was actually a counselor. It actually was a disciplinary. At one time, you know, you could spank kids. You know, so he was, and he had so much, people loved us so much. When we lived in a corner house, and in my teenage years, when we would cut the grass, almost monthly, people, young men would come by the house, drive by the house and say, Mr. Ferguson, I hated your guts, but you taught me discipline. But it didn't happen, it didn't happen to me, you know, because my father, it's easy to tell somebody your story when you're not connected. And I had the greatest, I ended up with my father died, I hated my father. We never had a lights turned off because I could have been the man that he was. You know, so I actually see a picture of my grandfather until I was 35 years old because my grandfather was a Rolling Stone. My father could not talk about him, and my mother could not talk about her father. So a lot of my issues came from slavery, as you said, generational, that kind of stuff. So basically at 23, when I finally got a good job and got insurance, I was able to get help. So I saw TV for the first time. Everybody's heard the word depression. At 23, in the 70s, now the 80s, I didn't even know mental illness was an issue. I know there was mental illness. As a kid, I saw Bob Newhart show. We heard about psychiatrists, but black people didn't understand that stuff back then. We just thought it was something funny. But basically, once I was able to see a doctor, the first doctor I went to, I saw a pamphlet in there, and he said that if you have depression, you can't think, you can't focus, hard to sleep. I went to my doctor, and he said to have depression. But getting back now, once I forced my therapist after 4 times to see a psychiatrist, he diagnosed me bipolar, OCD, and he had, and what he did was he had me on Prozac and lithium. So today, what's happened now is that NAMI, since 2016, NAMI has came in my life. And what's happened is that if I had NAMI 20, 30 years ago, I wouldn't be in this situation. But NAMI's embraced me. I've had a mentor. Some of you know Kenya Phillips. We're going through ups and downs and battles and stuff like that. But because of her, somebody values me. You know, I'm in leadership, and I was in a meeting the other day, and they told me I'm going to be actually teaching soon in a behavioral health center. And I don't have a degree. I'm a CPS. So the best things happen to me is being a self-advocate. Even though I've had therapists, good therapists and bad therapists, and psychiatrists, I take it upon myself. I should have a degree from YouTube University, but watching videos and stuff on mental health. So I want to thank everybody for the time, and this is just a part of my journey, and I hope Joanne and everybody here that I can be a great asset with the Atlanta Auburn NAMI affiliate. Thank you.
Thank you for that presentation and allowing us to hear your story. And we're glad now to receive our last person who will share in her own voice, Ms. Patrice McGee.
My name is Patrice McGee. I am excited to share my story, but also a little nervous, which is interesting for me because I actually speak about mental illness and my own journey a lot, and so just kind of trying to get my bearings together. But for me, I was not diagnosed until about 2 years ago, and it was during a very mentally abusive relationship. I got into a relationship with a young man at the church I was attending, and I was in the choir, and he was in the choir with me, and then friends found out that he was cheating, and for whatever reason, I decided to stay in this relationship, and I actually lost friends because of making that decision. Later on, after I stuck with this, and he was actually the one who encouraged me to go to therapy. He actually, before I found out he had cheated on me, was telling me that I had a lot of tendencies of doubting myself and thinking badly about myself. But when I think back about that, I understand that he fed off of that. He saw that, and that's why he sought after me, so to speak. And a few months after trying to stay in this relationship, he actually, the night that he broke up with me, I was actually at choir rehearsal, and it was the first time that I had spoken in front of people about my struggle with mental illness, because I was diagnosed with major depressive disorder and anxiety with panic attacks. And that same night where I talked about my struggles and actually spoke about having suicidal thoughts, he came to my house, broke up with me, and got in a relationship with another young lady in the choir. I walked away from my church, that location, because we have several other locations. And so that was helpful for me because I was able to make that move, but at the same time, I was still broken inside. And him pushing me to go to therapy was, God's own way of getting me to deal with my own issues, because prior to him, I knew there was something, but as, Howard has said, as Jade mentioned, we don't talk about that stuff. It's not something we speak about in the Black community, and I was depressed growing up. I did things to try to make people like me so that I wouldn't be alone. I had a lot of anxiety, especially when I went off to college, because I was the first person in my family to go to college, and so there felt like there would be something great. And so actually pushing through that and kind of just partying all the time and putting on that facade like everything was okay, because I would go nights and nights and nights without sleeping and just pretended like everything was cool. Everybody was just like, oh, it's just because it's college, she's up partying and she's doing homework and all that stuff. So it was looked at it that way. And once I graduated college, I did not have a job lined up. I had a job lined up, but it actually turned out to be something that was, for lack of better terms, it just wasn't good for me. And I ended up being homeless. And so I stayed on the street for a while, or slept in my car. And then I moved into these college apartments, lied and said that I was still in school, because they looked at me and thought, she looks like she's still in college, why not? So I did that, and then thankful to God that, the world, it's very, very dangerous, but at the time, the things that you see now weren't as heavy as they are now. I actually went on Craigslist and found a place to live with this random person that I did not know. And I ended up getting sick and had to move back home. And that's when I had my very first panic attack that my mother saw, but we still didn't know what it was. And I ended up being hospitalized for some days, but it was alongside of another issue that I have called angioedema, which causes you to just randomly swell up, and it can be triggered by stress. And so dealing with that was when I first really truly knew something was really bad, but I still continued to go on, and that was in 2009. I still continue to just push forward, like, I don't see my mom dealing with this, I don't see my sister dealing with my aunt, my grandmother, so it's just, they probably have these issues too, and they're hiding it, like, so I have to do it too. But when it came to that relationship, me having to go to therapy because I found myself sitting in the car outside of my client's building. My vice president was there for a meeting, other high-level people for meetings that I had to sit in, and I found myself not even being able to go inside. And I found myself back and forth to the bathroom because I was having so many body issues because of the mental illness taking its hold from a physical standpoint. And I got in the car, I called my insurance company, and I said, somebody's gotta help me. I have Kaiser. If anybody knows anything about that, everything is housed into one thing. You don't call a therapist and say, hey, do you take my insurance? Everything is through them. And that was August of 2017, and I was told that no one could see me until October. And I just couldn't understand that. And so then I decided that maybe it was just meant for me to die. And I sat there and I just cried and I cried and I cried. And then something told me to pick up the phone and call again. So I did. And I finally said, hey, other things are happening. They allowed me to see a doctor. The doctor, I actually had a breakdown there. She told me that she believed that I had depression and anxiety. And they sent me to see a therapist that day. And a lot of times you hear people say that they have to go through all these therapists. The therapist that I got is the therapist I still have today. And I'm just really, really thankful for that. So just continuing to work with her, and that's not to say that everything is better. I was recently hospitalized for a suicide attempt. And thankfully, my sister is a doctor, so she understood things, and they were trying to commit me. She was able to have a conversation with the doctors and allow me to be released to a family friend. And since then, I continue to be connected to that family friend, and she's been kind of my support system here in Georgia because I don't have any family here. Today, I do speaking engagements for NAMI. I speak at other mental health community affiliates. I write a blog about mental health. I am the outreach coordinator chair for the Atlanta Auburn affiliate. I work a very well-paying job. I'm working on my doctorate degree. And just excited to see what comes.
Can you stand on the stage now? Could you go to the stage, Jade? Could you go to the stage? We'll do about 5-10 minutes of questions that you guys may have of them. Do you all want to sit down? Feel free to get comfortable. I'm sorry, I didn't make it up there to pull chairs.
You had some good therapists and some bad therapists. What?
Can you stand up when you ask the question?
Loud, please?
Thank you.
Okay. I just want to know what determines a good therapist and a bad therapist. In my mind, I'm thinking, but tell me what you feel.
When you have a therapist, when you're talking and they're doing this, looking at their watch, or I've had a therapist to say, I know just as much about your family as you do, You're trying to talk to their pain. And we have a therapist but does a write-up for you and doesn't call you back. I've had those therapists, and I've had great ones too. But basically, even when I was young, I said, if you have a good friend, you don't need a therapist. And that's what a therapist you want to have, is somebody's your friend. Somebody cares about you, not just about the job.
Some background knowledge.
Well, somebody cares about you, not just the job.
I agree. Like for me, I have my regular psychologist and I have my psychiatrist. And then I also have a doctor that I do group with. And my psychiatrist, my sister laughed when I told her that. She was like, really? But like my psychiatrist, like she gives me hugs. And really, in a lot of times they say that, you know, they're not supposed to touch the patient. And so my sister was very surprised by that. But I'm really not, I don't like to be touched. So it was kind of like interesting that when she did hug me, it made me happy. Like, and she would tell me like how good I'm doing with therapy. And so it's crazy because I hear Howard saying he's been through all of these different therapists and stuff, and for whatever reason, the therapist and the psychiatrist I got it right the first time. And my psychologist, she is a Black woman, and that's what I wanted. I wanted someone that could understand my plight, my struggles. So I can't imagine having a bad therapist regularly, but when I did have my suicide attempt, I had a bad therapist that I had to see, and it was a horrible experience because it was just like, he was just like, so what was wrong? Mm-hmm. Oh, okay. All right. So you're good now, kind of thing. And it was just like, wow. So I went home feeling defeated, but thankfully I was able to have a follow-up with my regular therapist within that week, and I felt much better once I spoke to her.
So with me, it's pretty much the same as Howard and Patrice. I've had enough therapists and psychologists, both a man and mostly women, Black and white. I had a psychologist, a white male, who instead of me telling him my issues, he was telling me his issues. He was telling me his issues, and he was diagnosed. And he was telling me his two sons' issues that were diagnosed. So I'm like, why am I here? Right, like I need to sit where you're sitting and get paid the money that you're getting, and just maybe listen to you. I had like my more recent one, and we're not together anymore, but I will say that I've had her. She was a Black psychologist, one of the top psychologists at Grady, and I will say this, it just got old because we weren't doing anything else. I just felt like I was stuck where I was at, and I needed to move forward, and that wasn't happening, and so that's not good for me. So I currently today have a new therapist, and we've only had 2 visits, but I will say we put everything out on the table. Like I told her, even if I don't like what you say, just say it, because I'll respect you better if you're honest with me instead of just capping my head, okay? And so please just don't sit there and write, like you said, don't sit there and type or write and look at me with that blank stare. Like I need to feel like you care. So she's so far, knock on, so far it's okay. We're both honest with each other, and we'll just see where that journey takes me.
Any more questions?
I just have a comment that I can see your story and I can hear your story. I've been in somewhat of the same positions that both of you guys have been in. I haven't been homeless, thank God, but for the most part, the bad relationships, the things that would take you down that road. I myself was diagnosed with major depression, panic attacks, anxiety. My ex-husband took me through some stuff, but for the most part, by going through group therapy and actually talking to people about it, I actually learned how to deal with it and cope with it. And my final thing came to, I just knew that there was an ending coming to the situation that I had at hand. So I applaud you guys for being able to tell your story, and I applaud you guys and encourage you to keep telling your story, because there are more people out there that need to hear your story and know that just because you're human and you have good jobs and you keep a smile on your face does not mean that you do not go through things. So I do applaud you guys for that.
Okay, we're gonna wrap up right there, but Howard, Jade, and Patrice will be available later on. And we're just gonna keep moving with the presentation. And so next we have Darlene Henderson. We'll give her a round of applause.
And we're so grateful again for them sharing their story, and even for all of you all being here today. I think we can all leave, feeling hopeful about the fact that we're here today, and that there are some, future hopes that will be achieved because we're starting to break the stigma by sharing our story. So we're really excited about that, because as we know, in our community, there are people's, the attitudes and their beliefs about mental illness will set the stage as to how they interact. So again, as you had complimented and said, this is setting the stage. It's changing the attitude about mental illness, and it's allowing us to embrace more one another and share our stories, but ensure that we have the resources that are available to help others. And so that's what today is all about. It's been a wonderful conversation that we're coming to the conclusion of. And the attitudes and beliefs, previously they have been impacted by the stereotypes, the media, and so many negative things that have given us a negative attitude about it, but we can change that. We start today and we continue on making a change, because in our community, it had been said earlier, some people turn to faith, and that when they're dealing with mental health problems. And I will attest that even the faith community is making advances. There are more people that are impacted, clergy, their children, they're impacted, and they're therefore now sharing the story. And NAMI can partner with them, as they already are, by having evidence-based information and resources that are available to our community so that we can change that narrative. Just some mental health facts before we go to what's next. Approximately 1 in 5 Americans will have a mental health problem or challenge in any given year. Again, that's 1 in 5 Americans will have a mental health challenge in any given year, yet only a little over 1 in 3 individuals with a mental health problem will receive mental health services. And so we hope that by conversations such as this, there will be a change to that. And then also 1/3 of individuals with severe mental illness who receive community health services after a lengthy stay in a state hospital achieve full recovery in psychiatric status and social function, and another 1/3 improve significantly in both areas. So that's what we need to celebrate too, that recovery is possible. We've seen that by what you just heard today from these individuals within our own voice. Many of us are here today. Either it may be professionally that you're here, it may be that you're just passionate about helping, or it may be personally, such as myself. Many of us, our families have been impacted, but this can be different. And we know that recovery is possible. So give yourselves a hand for being here. So finally, what's next? That's what is important. We can come, share our stories, hear wonderful presentations, education, but what's next? And that's what we want to leave today with, having a plan, having some action items about what's next. So we're going to think about that and allow you all to share. What are some of those things that you feel are next that we can do to make a difference in our individual lives and in our community? We'd love to hear that from you all. as Miss Joanne will come forward. Let's give her a hand again, our president.
No, can you just use the stickies and tell me, what do you want us to do next as an affiliate? How do you want us to keep this conversation going? I've run out of ideas personally, because this is the second event. And so I don't have any ideas, and I'm convinced that the way that I'm approaching it is not the way that it needs to be approached. So just having you ladies here and helping me to brainstorm what that should look like, that's the approach that I'm gonna try next. The doctor suggested that we partner with the mental health court. So I'm going to be looking at my leadership team and getting some assistance from them doing that. It's a state conflict of interest for me, so I'm not able to go to the Fulton County Mental Health Court. But if I don't get somebody stepping up, person that I am, that is a bipolar. It's bipolar 1, it's bipolar 2. I was hoping the doctor would talk about that. I mean, they're totally different. And I'm saying, you know, it goes back to really what my son says and what I'm really thinking in my head. It's that I need rappers to do their part. Football players, I love the NFL. People tease me about saying I'm a die-hard Patriots fan. I am for a reason, because they got NAMI on their lapel when football season starts. So they're advertising. Football players, basketball players, baseball players, they're talking about it. But it's not trickling down to our community, to the foot soldiers. It's not trickling down to that little boy. I went to an event at a church. The little boy was crying. I walked over to him and grabbed his hand. No, nobody in the church saw that. And I'm saying, there's something wrong. He shouldn't be crying. There's something happening that he is breaking down. I hugged him, I pulled him to the side, and I said, I know something is going on with you, but I also know you don't know me. Show me your loved one. I had a conversation with the loved one never followed up. All I could do was pray for that little boy, because I said, something serious is happening, and I hope I don't turn on the news and he committed suicide. So, and two, we're able to all walk around, and we're sitting at lunch with our friends, and we're saying, you know what, I felt depressed today, and it's okay. You know, I suffer from mood disorder, or my thoughts are racing at night, and it's okay. It doesn't make me any different than anybody else. Then I think as a community, we end up still getting stuck.
The old people gotta move up, and the young people have to take over, because old people have shoved it under the rug, and I'm old, and we've shoved it under the rug for too long.
Tell the truth. To piggyback off what he said, I have some older aunts that live in the community, and I have a cousin who I felt he's older, he's in his 30s, but I'm like watching him throughout his life, and I'm like, yeah, hey, you don't see this elephant in the room. And they just wanted to pray away. And he's going through some things now, and he's far off from healing and health. You know, I said, you know, you guys need to get him to a hospital. He needs to get diagnosed. Something's going on. But we praying it away.
Right. And when you asked the question about the therapist, I talked to my brother. That's like my best friend. I breathe his ear, all of that. I'm like, yo, that's what you need to do. When that therapist is interviewing you, you better be interviewing the therapist. Here's your questions that you better be asking. It's a two-way street, okay? If you don't feel comfortable with that therapist, you're not going to discuss anything. And then people walk in, and a lot of times they think the therapist's role is to solve your problems. No, it's not. It's to create an atmosphere that you feel safe enough to disclose what is going on. Then they're going to give you different coping strategies. Why? Your coping strategies failed, and that's why you're in the therapist's office. And then we have to be careful that the relationship that you have with the therapist can't be your ride or die relationship. Because I left therapy because I got burnt out. I said, when I meet my clients, I go, this is a series of hellos and goodbyes, okay? Some things I say are gonna piss you off. Throw them in the trash. Anything that I say good and I bring to your life, hold on to that. But please understand, I get burnt out just like you have issues. I may be here tomorrow, I may be gone next week. You can't just rely on me. You're only sucking up what I'm bringing to the table, and anything else, you gotta build you up. I always tell everybody, what is your toolbox looking like? If that toolbox is not, a builder isn't using tools that they can't use anymore. They're going, I gotta go to the store because it's the newest thing. It's gonna make me build something easier. And so that's what I think we have to do as a community. How?
This Thursday, talking about young people, this Thursday I was at the crisis intervention team that you approved of, and two of the police officers were saying, one that was working like with Emory, I've got the other was another one, but he was talking about how these kids with tests, they're committing suicide.
Correct.
It's a big deal. So one of the other ladies there, she helped start UGA's NAMI campus program. So that's something, one of the things I want to do. So I talked to Sarah, and I said her some things. So she's very excited when I show different things. And she said, you know, talk to your affiliate, talk to you about it. But like you said, Morehouse.
That's me. Grab that off, please.
You know, Morehouse, I talked a while back, they have psychologists and people there. And not only can you do a support group there, you could do all the programs with on campus. So you go into an audience of people who are challenged. These kids come to college, a lot of them can't, like around final time, that's when some of them commit suicide. So you have a captive audience there. And all you need is somebody like from the council of government and a teacher. Just need two people to get together. And so you have people right there that have that problem. And these doctors, these teachers and stuff don't know what to do.
But remember, if you're going with the NAMI model, it has to be the NAMI way. And so that sometimes...
NAMI on campus, that's the program.
Right. But sometimes people get a little discouraged because NAMI says, here's my model. NAMI also says, no, you can't charge for these services. So sometimes in our community, that person says, well, I can't do it anymore because I need to get compensated. Some things you can get compensated for, some things you can't get compensated. So at the end of the day, what I hope we all walk away with is I need people that are passionate. I need people to realize that you may not get paid on this earth. You see what I'm saying? When I'm in a store and someone goes, yo, Miss Joanne, I'm like, oh my God, it's calling me. And then somebody runs to me and they're like, you told me that whenever I wanted to, I could stop being a victim. I'm not a victim anymore, Miss Joanne. I'm like, okay. You know, that makes me feel good. When I'm talking to my own family member and he's like, hey, I got up today, guess what? I'm out, I'm doing blah, blah, blah. I'm like, I knew you could do it all the time. And so the one thing that I'm gonna leave you with is we have to make sure that we're not enabling our loved ones. We have to do that. That's the hardest thing that I personally had to do. I said, I'm not coming on a plane anymore at the spur of the moment coming to save you, because guess what? You got your sister with NAMI, you got your sister the social worker, you got your sister the best friend. She gave you all the tools that you needed. Either you pull within and you use them, because I know you can, or I'm not gonna deal with you anymore. That was the hardest thing that I had to do, and now he'll call and do his check-ins. I'm doing this, sissy, and I told him before, if you don't want to do it for you because you're so tired, I know you better be doing it for me. And so we gotta just keep this conversation going, ladies. I look forward to all you all being a part of NAMI. I'm so excited. I'm just already claiming this. Do you all have any comments back here? Like two?
Everything was fine today. Wonderful.
Good, thank you. Thank you. And I think it's important too that we bring our Latino brothers and sisters into this community, into this conversation, because it troubles me with ICE. Who's dealing with those feelings of these kids? And I said to myself, we're creating the next terrorist, you fool. Look. And you're doing it yourself. I mean, post-traumatic stress disorder is real. I had a friend that lived in a black house. Every wall was black, and I thought it was cool until I went to school and got educated, and I said, oh my God, he was always that depressed, and I just thought it was cool walking into everything being black. No, it wasn't cool.
To piggyback just real quick off that, I was thinking about my children used to go to a school in Buckhead where there were a lot of Mexican children at that school, and I remember when our president was placed in the office, and the next day we came to the school, and the school had to put up signs all over the school that said, you are loved, you are welcome. It was, and I'll never forget that. Wow. You know, these little, because it was a predominantly, those were the most of the kids, and I just remember, wow. But it was great that those teachers and recognized, hey, by the morning we gotta, we gotta welcome these children in.
Yes. So you all can access me by going to the website, phone number there, email. You can access Jade, you can access Patrice. Please don't let this be the end of our conversation. If you find, just carry it, and the Atlanta Auburn affiliate has done what we needed to do today. Yes, that's why I put it on everything. I said, we put the website on everything. I'm so proud of our free website, and it's funny, no, don't film this.
Okay.
Other affluent people were upset that we finally got a webpage.